Okay, so Dr. Jacobi, welcome to episode 1 of the Health Path podcast. It's a real honor to be able to have you on as the first episode.
Well, thanks for thinking of me for your first episode.
Dr. Jacobi, before we dive into the world of SIBO, would you be happy just to share maybe the short version of your story and background for people that might not be familiar with you or your work?
Yeah, sure. So I'm a naturopathic doctor. I practiced in the wild state of Montana for about 7 years back in the 90s and early 2000s. And then I moved to Australia in 2005 and have been in private practice here. But when I learned about SIBO, which was only about in 2011, I had never heard about small intestine bacterial overgrowth, the most common cause of IBS. And me as a naturopathic doctor with a focus on gut health and functional digestive disorders, I was sort of flabbergasted and also like, wow, this is how come I've never heard about this? So that really prompted me to dive deeper into what SIBO is and the naturopathic treatments of SIBO. And in the process, have a testing company in Australia called SIBO Test, as well as an educational website called the SIBO Doctor that aims to educate practitioners to not just about SIBO, but other functional digestive disorders as well. And also I have a lot of stuff for patients, and I created the biphasic diet and lots of different resources that really help practitioners to streamline their treatment protocols a lot more, because as a practitioner, I know how frustrating it is to not have the right tools, right? So that's really been my journey over the almost 10 years now. So it feels pretty great to have all that knowledge and have all those resources made available. A lot of them are for free. So it's been great to talk to people all over the world that are using it. So that's very gratifying.
Yeah, it must be. I think what you've done for the industry from a SIBO perspective is just huge. So thank you on behalf of all the practitioners out there, I guess.
Well, thank you. Yeah.
So you've mentioned that SIBO is the most common cause of IBS. Are you happy? I know this might be challenging in some ways just because of such a deep dive that you've done into this, but there may well be some listeners who aren't that familiar with the concept of SIBO. So would it be okay just if we, in a sort of a short period of time, take a step back and sort of discuss what SIBO is, maybe some of the new terminology that has come out in regards to this EMO or IMO concept as well, and then we can start to discuss some of the intricacies of SIBO itself.
Yeah, of course. So SIBO stands for small intestine bacterial overgrowth. Now, your small intestine extends from just below your stomach all the way to your large intestine. And it's really the area where you digest your food. And it's meant to have very little amount of microbiome or bacteria that are present there. So it's not supposed to be sterile, but there's supposed to be not as many bacteria as in the large intestine. So the large intestine is predominantly where the microbiome that you've heard so much about lives. And the small intestine is really more the surface area for the proper process of digestion. When you have a bacterial overgrowth in the small intestine, that is classically termed small intestine bacterial overgrowth, or SIBO. Now, there's lots and we'll probably get to many of these causes, but there are many underlying causes that cause SIBO. And therefore, the treatment generally to remove the bacteria can be herbal, can be conventional, but then addressing underlying causes can really differ depending on what the underlying cause is. So when the bacteria are overgrown, and the bacteria are not the bacteria that cause food poisoning or are generally pathogenic in normal ranges, they're just in the wrong location. So when that happens, you actually feel the effects of SIBO in terms of the symptoms that we classically see with IBS type symptoms. So bloating after meals, often a very disrupted bowel pattern. You can have diarrhea, you can have constipation, you can have an alternating pattern. and abdominal pain and reflux and lots of digestive symptoms, as well as what we call systemic symptoms. So often people have histamine intolerance, where they have hives and rashes, or headaches and breathing problems, or they have acne or rosacea, they have restless legs. So there's a slew of conditions that are associated with this very common condition. And that's why I think it's been so central to and so interesting as a practitioner, because it's like the hub or the center of many, many underlying conditions. So the bacteria that are there, that are in the wrong location, when they meet your food that has come down and is supposed to be digested by your digestive enzymes, etc., when they meet this food, they eat that food and they produce gases. And one of those gases is hydrogen, and the other gas is methane. And methane typically causes constipation, and we'll talk about that in a more separate conversation or discussion about that, because it's now been sort of reclassified. So really classically, SIBO should have some element of hydrogen, and also have an element of mixed bowel patterns. Generally, we see that, where we have loose stools followed by a few days of no stools, and etc. So yeah, so those are the two types of SIBO. And again, there are lots of different underlying causes, and there's no one size fits all for treatment.
Yeah, and I think that sort of hits the nail on the head with the complexity of SIBO. It's this idea that there are so many different underlying causes, and until that's addressed, it's sort of symptom management, I guess, ultimately, or a continual eradication of an overgrowth that keeps sort of relapsing and coming back.
Exactly.
And you've come up with, I guess, your 4 categories of underlying cause from memory. So I know that I've downloaded a sheet before that kind of breaks this down. So do you want to touch on that a little bit as well?
Sure. So when we think about the most common cause of SIBO, that would be something that disrupts the motility, and I'll explain that in a little bit. But the 4 categories of underlying causes of SIBO is anything that disrupts the small intestinal motility. So in your small intestine, you have something called the migrating motor complex, also known as the housekeeper wave. And it's part of your nervous system, kind of like the brain in your gut, that helps you to sweep out bacteria that have been left behind after eating. I mean, we eat food that are covered in bacteria if you eat raw foods or something. So it's impossible to keep bacteria at bay. And so that cleansing wave is really meant to sweep out the small intestine and stop any sort of fermentation in the small intestine. So when that's disrupted, and that can be disrupted or damaged by different causes. So one of those causes would be what's called post-infectious IBS. So where we actually have a true case of food poisoning with something like Salmonella, Shigella, E. coli. Something happened on your trip to Mexico or wherever, or Southeast Asia, wherever you went, you had some bad street food, you got food poisoning, or you went to a salad bar in your hometown and you got food poisoning. And for a couple of days, you were really sick. Those bacteria actually secrete a toxin called cytolethal distending toxin that then triggers also an immune response from the body. And the immune response, we all should be well aware of this now from COVID-19 discussions. So when your body encounters a pathogen, it actually fights back by secreting an antibody against that pathogen. Now, in the case of SIBO, what happens in that scenario is that the body accidentally makes an antibody against parts of the migrating motor complex. So it's an autoimmune response. That is actually a very common underlying cause that disrupts the motility. Now you can't really properly clear bacteria out. And those people that have this type of scenario do really well on a type of medication called prokinetics. And prokinetics are substances that aim to reset the normal motility of the small intestine. So that's the motility. But in that category are others like mold exposure or mold toxicity, right? So if you live in a moldy house and exposed to mycotoxins in your environment, they can actually also cause toxicity in something called the myenteric plexus, which is another part of the nervous system of the gut. So that can also slow things down, or hypothyroidism with the wrong, or just T4 medication, or chronic infections. So that's one category. Another category is just your digestive juices are too weak, right? So we have digestive juices like hydrochloric acid that's not just there to digest your food, but it's also there to kill bacteria that are coming in through your mouth. And when that's really low and chronically very low, then you've lost this ability to kill bacteria in this vat of acid. So that's one example, or digestive deficits such as improper bile flow can also be an underlying cause. And then another really important category is what we kind of think about as obstruction. Something is happening in the small intestine that doesn't allow bacteria to leave the small intestine. And that would be scar tissue, like you had your gallbladder out, or you had a C-section, or you had or even you have endometriosis, or a number of other conditions where you either had a laparoscopic exam or you had abdominal surgery. That actually triggers scar tissue formation, and scar tissue can sit or attach itself to the small intestine and the abdomen, and then sort of pull it to the side, and then it creates this, what I call a kink in the garden hose, and the flow is just not really appropriate through that section, and then you can have bacterial overgrowth, anything above that kink. So that's another one. And then there are also certain medications that basically slow down the gut, etc., and cause other mayhem. So medications, obstruction, digestive deficits, and motility are all categories of underlying causes that have other conditions in that category. I'll go through it in detail in my SIBO success plan for patients, but also the SIBO mastery program that I created for practitioners.
Brilliant. No, it's such a helpful resource just to give us a little bit of structure to our thinking, I guess. And what route that we need to go down. So brilliant. We've kind of touched on obviously symptoms from a gastrointestinal and extra-intestinal perspective. We've talked about underlying causes and your categories of causes. And you've mentioned sort of the SIBO element of things and then this methane element of things. So are you happy now to kind of perhaps dive into the methane side of things? Because obviously from a technical perspective, these methane producing organisms aren't actually bacteria. So we have this sort of new term of intestinal methanogen overgrowth that we need to start being mindful of when we're looking at our test results.
Yeah. And I'm really happy, and I'm just realizing that it says Mark White on the bottom of my window, and that's I don't know why, but that's my husband. So okay. I don't know how I got onto this Zoom thing. But anyways, yeah, so I'm really happy about that name change because, I always suspected that methane was, so methane, just in recap, is a gas that's produced by organisms that are actually not bacteria. They're an ancient species called, or group of organisms called archaea. And these are in the group of what we call extremophiles. And extremophiles love extreme environments. You can find them on the bottom of the ocean. You can find them in your gut. You can find them in lots of different places. And they, the thing about methane that always disturbed me even when I first started out is that methane production can be completely normal in people, right? So you can have a situation where, the way we actually diagnose SIBO is through a breath test, and we'll probably get into how to diagnose it and what that means and how to do a breath test maybe. But on a breath test, you can see the two gases that I mentioned, so hydrogen and methane. And methane can be very high or can be elevated typically, but the patient is not constipated, in which case I wouldn't necessarily think that that's a problem. So methane is produced by this organism called Methanobrevibacter smithii, which is this archaea extremophile that lives in our gut, in some of our guts, not everyone's. But, evolutionarily, it was always a real advantage for us to have this organism on board, because when we were still hunters and gatherers, we ate a lot of very fibrous tubers and foods that were very difficult to digest. And so for methane to be on board, what that meant is that you could slow parts of your digestion down through your digestive tract, so that you could actually extract more calories from that food. So there was a reason why that organism was actually present. But now that we are in a fast food society and we have far more caloric availability to us, it's really not a very advantageous bug to have on board to slow down our digestion, because it can cause constipation. That's the primary complaint of people that have very high levels of methane. And the situation is such that it used to be called SIBO-C, or SIBO constipation. But the fact is, there's two things wrong with that. Is that A, it's not a bacteria, so it's already a misnomer, right? It's basically an archaea, it's a different organism. Secondly, sometimes it's really difficult to interpret breath tests when you have high levels of methane. And that's because when you have very high levels, it can actually also be a contribution from your large intestine. So now, and it's very typical for us to see high levels from the beginning to the end, which usually means that you can't really pinpoint where this is in the gut, and there's just a general methanogenic overgrowth. And hence the nomenclature change of EMO, I call it EMO, which is just too funny. But you know, it's a good name because it's an intestinal methanogen overgrowth. And it's not typically SIBO. It is more complicated than that, of course, because wherever methane is, you also need to have the presence of hydrogen producers, because methane requires hydrogen to, or Methanobrevibacter requires hydrogen to produce methane. So it's not quite as clear cut, and there's still a lot of answers that we're looking for in terms of proper interpretation of EMO.
Yeah, it's really interesting because I certainly see if methane is elevated, it is almost always from the baseline sample all the way through to the 3-hour mark in the test results. So do we have any theories or an understanding of what could be going on there? I know that one of the most maybe original thought processes, it was just a stagnant gut, and these gases were essentially lingering potentially from the large intestine. So it wasn't necessarily that they did the test prep incorrectly, which was often what the lab might suggest as a common explanation. So is it really what you've sort of mentioned here, which is it could be anywhere along the digestive tract that this methane production is taking place, and that because it's associated with constipation, we're just seeing that sort of stagnancy, so to speak?
Well, it's also the gas dynamics. So, and what I mean by that is, if you think that it takes anywhere between 20 minutes to an hour for hydrogen to be produced from, let's say let me explain the breath test to your listeners.
Sure.
So a breath test is basically where you have had a day before you do the test of a prep diet. And the diet should be pretty strict so that you don't consume foods that are what we call fermentable. So no foods that actually are food for bacteria. So for example, a lot of starch or fruit, it provides food for those bacteria that then create the gas. Compare that to meat or other types of protein, mainly meat, that has zero fermentation potential for those bacteria. So you do the prep diet the day before, then you have an overnight fast, then you take a challenging substrate test sugar like lactulose, and lactulose is actually a prebiotic. Bacteria love it, right? They're fermented very easily. A certain amount of bacteria do. So then what happens is bacteria create hydrogen, right? Then that hydrogen has to be funneled, that takes about, like I said, 20 minutes to an hour for actual hydrogen to start being produced. Then it takes at least another hour for methane to be produced. So this has always been the difficulty with test interpretation, where you see methane rising in the first hour, right? Where logically it's difficult to reconcile that when you understand that it takes some time for methane to actually be produced. So we have to still work with old guidelines of rise of methane and stuff. And that's what I mean. We're still looking for some answers when it comes to methane, because it's not just as simple, or it doesn't have the same time frame as the fermentation of hydrogen. It requires, unless hydrogen is already there, right? So from the get-go, which means the prep diet wasn't really done, or what's going on. So this is what I mean. There's still so many questions in my mind about the gas dynamics of methane, hydrogen, and soon hydrogen sulfide, which is another receiver of hydrogen. It also takes hydrogen to make hydrogen sulfide. So it gets complicated, but methane really, I think if you have it from baseline and it barely shifts, that's really classic EMO from the get-go to 3 hours. It's basically a 3-hour test. And if nothing much changes, and you have a huge rise at the end of it, then you can pretty much suspect that you have some sort of combination small and large intestinal overgrowth.
Okay. And what are your thoughts on some of the research that has been published from a methanogen perspective? So obviously there's been literature discussing it being elevated in those with a history of anorexia, but also those who have obesity. And there was also a really interesting paper that I'm sure you've discussed on your podcast before around the cyclists and sort of elite cyclists having higher levels compared to the amateur cyclists. And what I
actually think you sent me that. Didn't you send me that article?
Maybe.
That was a really good article. Yeah, I think you did. Yeah.
And what really got me was the two papers certainly looked at anorexia and the elite cyclists, where they both had elevated levels of methane production. Different authors, but essentially the same hypothesis ultimately, which is for different reasons, had the microbiome adapted? So was there almost a deliberate shift in the microbiome to increase the extraction of calories? For the cyclists, because of the amount of training they were doing, with those with the history of anorexia, obviously because of a lack of fuel essentially coming into the body. So would you agree with, I guess, this theory? And is there anything else that, I guess, with your brain you picked up from some of this research?
Oh, I have a lot of thoughts on all of it. I actually, I have a whole nother thought in that, like, there's a lot more to the story, and I have to actually, I can't yet talk about it because I will have a guest on my show where it's a whole novel thought around that.
Okay.
So I don't want to give it away. Yeah, it's not.
Sure.
It's further along the line of microbiome, methane. It's not anything revolutionary, I think, although in my mind it makes sense. So, but yeah, so those two papers and anorexia, that makes so much sense. The wisdom of the body, right? That it actually, are there mechanisms in which we upregulate certain organisms when we require them to do our bidding, right? That's the fascinating side to that. So that, again, we're slowing digestion down so that we can actually extract calories. Although the cyclists reported no increase in constipation, right? So that was the interesting part as well. And when you look at an entire continent, so sub-Saharan Africa, 80% of the adult population actually has very high levels of methane, and they're not constipated. So this was the reason why it didn't make sense that just because methane is high, that we classify as somebody to have SIBO. So that I'm happy with, that now it's more intestinal methanogen overgrowth, which means that sometimes that is not, like, it doesn't necessarily mean you have to perhaps treat it, like as the case with the cyclists. So there's still a lot of questions I have about that, but also this idea that we are able to upregulate certain organisms is fascinating. And I think you mentioned that you'll have Greg Nye talk about hydrogen sulfide, who I had on my podcast, the SIBO Doctor podcast, and he proposed this idea that we have hydrogen sulfide producers like the sulfur Vibrio, Bilophila. There are actually a lot of other bacteria that have the capacity to produce hydrogen sulfide in different circumstances, more than those two, that we upregulate them when we are in a sulfur or sulfate deficit in our body. And I'll leave him to talk about it. He's way better at it than me, but it's an interesting theory. It's a theory. We don't know yet if that's what's happening. But papers like the cyclists or the methanogen overgrowth and anorexics could really be an example of this, where this would be an advantageous organism to have on board in different circumstances.
Yeah, and I think it's in the cyclist paper where there's also a bacteria that it might be Prevotella copri that they discuss as another organism that was higher in the elite compared to the amateur. And again, same theories.
And the whole phylum, I think it was the whole Bacteroidetes phylum that was elevated.
Okay.
In that, if I recall it correctly. But yeah, there's so many different things that what we're seeing now when we look at microbiome research is we're starting to understand the players. How the players talk to each other, we have no clue yet, So that's still on the horizon as to the interaction of different organisms and different, or even the whole metabolome, how, substances that are produced by the microbiome and how they interact with our immune system, etc. I know you and I can nerd out on this for hours, but maybe rein me back in to talk about SIBO.
Sure. No, I think it's fascinating. And it's in some ways, I think, important to show, unfortunately, the complexity of this. And secondly, some of these questions that we do have, because although it can give the indication of how complex and how many questions there still are, it can in some ways be quite comforting that, okay, well, it is possible this is an adaptive response. So let's go back into the history and explore a little bit more about this individual and what's been going on in their lifestyle. Because there's a paper that I'm sure I've seen you comment on again, and I can't quite remember the title, but it was around methane being this, essentially a gas that has antioxidants, anti-apoptotic, if that's the correct word, I always forget it, sort of mechanisms. So again, indicating that has the body decided to upregulate methane production because actually this gas does have some advantageous properties to it, certainly at the right dose, I guess.
I think that's a dose-dependent situation. I think you were like that I talked about in the methane masterclass, and it was a paper on, I think it was trimethylamine. And it was cardiovascular health, So trimethylamine oxide, I think, is the substance that's extremely damaging, and it comes from, it's also linked to a lot of meat consumption, etc. And it has actually a lot of cardiovascular damage associated with it to have TMAO, high levels of TMAO. And the presence of methane actually reduced that. So these are the fascinating side stories that, I understand that, look, if somebody has very high levels of methane and they've been chronically constipated, that this would be an issue and you do need to address it. But it kind of, for me, as I get further into my understanding of not just SIBO, but functional digestive disorders, microbiome, interactions, etc., I'm far less interested about the killing, and getting rid of and this old paradigm of you need to kill, because I think there are a lot more nuances, and this, I think, will be the art of our medicine and what we do and how we help our patients to regain their microbiome that interests me more now, to be honest.
Yeah, no, I think so. And I think it's an important message to spread and to understand to the best of our ability at this point in time. Okay, so that's some of the questions we have, I guess, in regards to this. Coming back to maybe the basics, so to speak. So, let's say we have someone, they have a positive methane test, which obviously, based on the North American consensus, is a result of 10 or higher at any sample within the 3 hours. Are you happy to discuss any almost sort of generic interventions that we might be able to consider in that sort of case? So even just, the fact that probiotics have been discussed as a possible intervention, for example. So again, even when we think about this, it's not necessarily the kill approach from an intervention perspective. There are some other, what I describe as maybe more gentle approaches that may have some benefit here as well.
Yeah, and this, I think this has been a long period of trial and error for many of us these past 10 years,
Yeah.
or even longer. So, for me, when I see somebody with methane, as you say, 10 or higher, unless they're constipated and everything else is normal, I'm not treating them for SIBO.
Okay.
What would change now with this nomenclature change is less of a focus on reducing FODMAPs. So typically, for those of you listening, the general treatments for SIBO are several categories. So one is the diet intervention, which I've written three diets now called the biphasic diet. You have the original biphasic diet, then there's the vegetarian biphasic diet, and the histamine biphasic diet that are free downloads from the SIBO doctor. So that was always traditionally what we used to help people that have SIBO. Then there are antimicrobials, whether they are antibiotics, so typically rifaximin or neomycin, or the combination of the two, or antimicrobials, so typically the berberine-containing plants for hydrogen, and garlic and oregano oil for methane. So, and then the third category would be sort of prokinetics. But again, prokinetics are really only useful for those that have a motility disorder, as discussed at the very beginning of this podcast. So those are the three things that we typically use. And what would change for me now is and what I've been doing with my very high methane patients is more of, rather than a FODMAP diet, so a low fermentation diet, because typically high protein diet, low carbohydrate diet, that is sort of the basis in a way of a low FODMAP diet, can be in and of themselves constipating. So, and what I found is that they were not that responsive to the biphasic diet. So I created the vegetarian biphasic diet for the vegetarians, but also I use that more with my methanogen overgrowth patients, or just an anti-candida diet, right? So an anti-candida diet typically is a lesser sort of starch, no sugar, and all these different things. So those are, what is changing, and I've done this already for a while, where I actually treat the methane people different. I still use my antimicrobials if methane is really, really high. And typically what Dr. Pimentel, who's the, very esteemed SIBO researcher from Cedars-Sinai in LA, he mentions, totally lost my train of thought now. Where was I going with that? It's late here, people in Australia. Not really that late. But anyways, it's, so what I was going to say is that his recommendation is to get methane below 3, right? For that patient to stop having constipation. And it's hard. It's really hard, right? To get it below 3. Very often you have to work really hard. And something in me was just difficult to continue treatment for people when they were doing much better. So I kind of stop when they're doing better. I don't try to get it below 3. If they are having much more regular bowel movements, everything is working fine, they're feeling better, I don't see the need to keep killing. So, because I think there comes a point where maybe we also overtreat, right? As mentioned before, that we could actually perhaps do more damage if we're continually treating. This is more with long-term diet restrictions and multiple antibiotic rounds, and also oregano oil and those types of treatments. So my focus has really been to educate practitioners about the many nuances of SIBO treatment. And that's really what I present in my SIBO mastery program, where one of the last levels is the advanced SIBO case management. And it's so beyond just, what we said, killing and all that. But getting back to your original question or statement, is that there are lots of other things with methane, like the partially hydrolyzed guar gum. That I use that all the time, and it works great, right? It helps to regulate the bowel. It does reduce methane a little bit. I don't really know. I don't ever just use PHGG, so I can't tell how much by itself it's reducing methane. But it gets the bowels going a little bit faster. Then there are definitely some probiotic, like Lactobacillus reuteri, but also Bifidobacterium lactis and other species that really have shown in research to help with motility, and then also improving short chain fatty acids and all the other bits. And really, this is my message to practitioners, to not just be myopic with your SIBO treatment, but to really understand it more fully, all the complexities of SIBO treatment.
Yeah. And I think I would agree with the partially hydrolyzed guar gum. It's one of those supplements that often clients will drop me an email saying how it's been a bit of a game changer for them. And there aren't many supplements where I get a consistent message like that. So that I would definitely agree that I've seen some really great responses with that. And the butyrate connection is a very interesting one. That sort of antagonistic relationship between butyrate and methanogens. Were you going to say something?
Well, I don't know if we want to go down that rabbit hole. There's a lot more to say about butyrate, so I'm just going to keep it
okay
to the SIBO thing.
Sure. Maybe another episode. No, I think that's really helpful. And I would agree there does seem to be a bit of an evolution in regards to how we support our clients with SIBO these days, which used to be the sort of the kill, kill, kill approach. And not that we don't want an element of that, but there is, it seems, this whole new area that we can start thinking about with our interventions and strategies.
Yes, I think so too.
Brilliant. Okay. And is there anything that, certainly from a methanogen perspective, Dr. Jacobi, that we haven't touched on yet that you think is important to?
No, I think that, I mean, again, it's a complex issue. And if we're just trying to do bird's eye view I think I was doing bird's eye, then I kind of dove into the ocean and went back to bird's eye. But basically, SIBO is a really treatable condition. And that's sort of the take home, is that you don't have to suffer. If you're a patient, you don't have to suffer with it. There are a lot of ways to make you feel better. And I think time will tell how we ultimately manage patients with SIBO. My suspicion is that there are different reasons for different people why they've become methane dominant, right? So, and also saying this, that those 4 categories, especially the post-infectious IBS, which is again that SIBO scenario where you had a case of food poisoning and then you developed IBS after that because your migrating motor complex was damaged from the bacteria. That doesn't really apply to methane overgrowth. It's very rare that we see that. So this is a whole, Dr. Pimentel suspects that something like to the order of 60% of people with SIBO have this type of scenario where they had a food poisoning and then developed IBS or SIBO afterwards. We don't see that with methane. So we have to have better understanding as to what caused that overgrowth. And I think those types of studies that we've mentioned are exciting insights into possibly different causes for methane.
Yeah, definitely. And I think actually I would like to maybe stress the role that stress can play within this as well, because we can
get me started, Alex. Don't even get me started, because it's so big.
Yeah.
It's so big.
And I think it's certainly something I've been guilty of as a practitioner. I think it's so easy to go down all of these different rabbit holes and not really appreciate that even in the context of SIBO, with all of these intricacies that we could spend weeks talking about, really, that stress is just a deal break. And I have had some clients recently that have really hit home the importance of just getting the foundations right as well. Even if it's not the underlying cause, it's still a deal breaker if it is now in someone's lifestyle at an excessive amount.
Absolutely. Stress affects every part of your digestive process. So it's a no-brainer to really have that conversation with your patients. And it's not just about, sometimes stress is an overused term. People don't even connect to it anymore because they're like, well, but I use words like overwhelm or inner tension. And it's pretty much, I mostly see in my practice now patients that have really failed all kinds of treatment. And they come to me sort of for a last resort, and they really tried a lot of things. And it's an underlying consistent similarities between these cases that have really what I call an overstimulated fight or flight. So that is, I think, if we can help our patients to reframe that and learn how to deactivate, or at least have spent some of the time in rest and digest and not always in fight or flight, I think that can sometimes be more powerful than anything we do.
Yeah. And I guess appreciating it is this sort of bi-directional pathway, the idea that stress from a psycho-emotional perspective is going to influence it, but is there a part of it which some of that inattention they're experiencing is coming from some of the physiological imbalances?
Right? Yes, the
So
whole
it's
gut-brain axis.
a vicious cycle.
Well, but if you think about, there's so much research into adverse childhood events, right? And starting off with a bad microbiome. So adverse childhood events is some sort of, it's trauma, is stress in childhood. And these children have very different microbiomes. So it really does not surprise me. And so, is that setting up some sort of feedback loop for the amygdala, for the fear center, for all of that to put a patient into this chronic fight or flight? These are really interesting questions. And I do so much more work around stress, and I have the great fortune to have in my practice a hypnotherapist, a gut-centered hypnotherapist that I can refer to, and can do long distance and recordings and help people all over the world. And this is, I think, absolutely been a game changer for many of my patients.
Yeah, absolutely. Brilliant. And one thing that's just popped into my mind, Dr. Jacobi, maybe it's just sort of worth flagging. We don't need to go down the another rabbit hole, but traumatic brain injury is sort of a factor that we need to be thinking about in someone's case history.
Yeah. So, and there, if you listen, I don't know about my podcast, it's called the SIBO Doctor Podcast. And I interviewed Kayla Sandberg Lewis, who is a biofeedback specialist in Portland, Oregon. And she is also a specialist in traumatic brain injury. And what we originally thought about brain injury, it doesn't have to be really severe brain injury. It can be falling off your bicycle as a child, or losing consciousness briefly. We all have instances where I was like, I can't believe I'm not walking around with chronic brain injury, because I've had so many incidences where that could have happened. But we know that it really does affect the motility of the upper gut, and even for years after the incidents. So, and that's a really tough one, because not everyone has access to these ways of getting assessed for traumatic brain injury. It's very difficult. So, but I do have it in my I have a questionnaire, a free questionnaire called What Caused My SIBO, and it's in there so people can use it, download it, bring it to their practitioner, so that they hopefully they know what they're doing, and they can look at that patient and sort of assess them appropriately for the underlying conditions. So, but it is a tough one, but it just goes to show that even something like briefly losing consciousness, or playing sports, right? Playing rugby, playing football. These are really difficult for the brain. Even the brain is basically lives in this little vat of water, and it can, even if it moves from a rear ending or whatever, it hits the front of the skull, and it can really get bruised. And so, I'm not a brain injury specialist, but there are, that's a whole nother field. This is functional neurology that works with vagus nerve, works with traumatic brain injury, biofeedback. All of that is so exciting. And I've had people that have done these types of treatments, and it just was amazing, the transformation. But it doesn't mean we have to start there. I mean, it sounds like things are really complex, but I see the complex cases. So somebody that's listening, that's a practitioner that sees day-to-day IBS, do a breath test. A lot of times things are more simple than we make them out to be here. It doesn't have to be this huge journey for people, but just be aware of that it isn't sometimes as easy, I guess, is the message.
Yeah, that's a really important message, I guess. Like everything, there's a spectrum, and sometimes some very minor changes are all that is required for someone to get improvement in their symptoms. So it's I almost having, I think, the confidence to go on that journey with the client, which is starting with the fundamentals and the basics, and if those don't work, then we kind of work our way through our toolkit ultimately.
Right. Exactly. And I think it's the onus is on the practitioner to continue to increase their toolkit and to stay current with developments, because it's a riveting field, I find. And it's just, meaning it's so fascinating. And, you know, I'm learning all the time, and I've been at this for a long time, and I'm still like blown away by what I'm learning, and what the microbiome and the, you know, the organisms that really outnumber us in many ways, what they're capable of, and how they can influence our day-to-day health, but also disease states.
Yeah, absolutely. Excellent. Dr. Jacobi, it's been an absolute privilege to be able to speak with you again. Thank you for sparing some time to come on the show.
Thanks, Alex. It's been fun. It's always fun talking to you.
Likewise. And hopefully we'll be able to get you back on sometime in the future to go down some of the rabbit holes that we didn't today.
No worries. I'll
Brilliant.
talk to you later. And
yes.
Yeah, if you can also, you know, sorry, you can edit that bit out.
Okay.
Yeah, pause it, cut it. But you're gonna have show notes where you put the SIBO doctor, all that, or not?
I'm hoping to. It's sort of, I think one of the challenges with HealthPath being such a big company already is it's so slow to get things done, because you've got to go to 10 different people for it. So I'm hoping that we can get people to help us create the show notes, and then have all the links, have all your documents and resources there as well, so we can share them. But that will probably take a little bit of time. So it's going to start with just the podcast. Basically.
Shouldn't have been the first. I shouldn't have been episode first, number 1.
I will push it along as quickly as possible.
Just do rev. That's what I do. You know, rev. It's like $1 a minute podcast transcripts.
Oh, brilliant. Okay. Thank you for the recommendation.
Anyways, so stop recording. Stop.